you so much for being here. And let's jump into the bio. So again, thank you, Brad Negrete, for being here. Brad is a licensed mental health practitioner in Nebraska and licensed professional counselor in Texas, and has spent his career focused on the intersections of the criminal justice and psychology fields. Brad started his career in the criminal justice field, working at a maximum security prison while attending a college. After experiencing a personal tragedy, he expanded his pursuit dual degrees and earned a BA in psychology and a BS in criminal justice, both from the University of Nebraska Omaha. During this time, Brad worked in mental health facilities focused on adolescents and their families. And in 2006, Brad and his wife relocated to Dallas, Texas. Brad worked for the Calling Community MHMR DBA Life Path Systems his entire 11 years in Texas and earned a master's degree in counseling from Dallas Baptist University during that time. Brad was part of the Assertive Community Team, ACT, and in 2012, he took his creation of the new jail diversion program in partnership with the Collin County Criminal Justice System. In 2015, Brad was promoted to Director of Crisis Services, serving as the face for law enforcement and crisis-related services as Life Path Systems became Collin Community's Behavioral Health Authority. In this role, he was responsible for creating and leading programs such as the Crisis Intervention Team, CIT program, After Hours Crisis Clinic, Disaster Response Team, Mobile Crisis Team, the Crisis Center, an 8-bed extended observation unit, and 14-bed crisis response unit or respite unit, apologies, and several other programs. Prior to Brad's 2017 relocation back to Nebraska, he was honored to be named the Texas CIT Mental Health Professional of the Year. Now back in Omaha, Brad is the Director of Urgent and Crisis Response Services for Lutheran Family Services. He serves on the Executive Committee for Heartland CIT, serves on the Advisory Board of the University of Nebraska Medical Center's Psychiatric Emergency Service, PES program, is a member of the Douglas County Stepping Up Initiative, a member of the Metro Area Suicide Prevention Coalition, and advising member of the design team on mental health services for Sarpy County, Nebraska's new jail. Brad is honored to be an adjunct professor at his alma mater, the University of Nebraska Omaha, teaching mental health and criminal justice. Brad, thank you so much for being here, and we're very excited to see your presentation.
Thank you. I'm actually really glad to be here. I appreciate the opportunity to actually engage with y'all and share something about two programs that I really have a great passion for. As I listened to my bio, I realized definitely need to shorten it down, but it also, as you can tell, I don't like just sitting around and not doing anything. I try to stay engaged with a lot of things, and although you can't see it real good, there's a lot of gray hair in here. And so that's definitely a part of it, of staying busy, but, trying to make some change. As it said in that bio, I went to school for psychology, for criminal justice, but I wanted to get into psychology as well because, my family, both, as I tell people, one half is a good portion have a mental illness. The other half have been on the other side of the law in the criminal justice system. And growing up, I saw that they engaged each other quite often, but it's taken a long time to see a lot of programs get set up to help individuals from both the criminal justice and mental health side. So I've been really fortunate to get on the ground floor when I was in Texas, and now coming back home, being able to move over to the director position at Lutheran Family Services just made it great. So it's right in my wheelhouse. I love teaching students. I was there this morning. I wish we had bigger classes. I got put in an 8 a.m. class, so I know my attendance was going to be pretty low. I didn't realize how low, but it'll make it interesting, for the students that do attend. So again, I appreciate being here, and we'll definitely jump right into the crisis response program. I'll take a little bit of break, answer some questions, and then we'll jump into the slides for the CIT part of it as well. Cindy, I see your cat's joining us, so that's awesome. So hey, it happens. I've seen tails flick across cameras. I've seen paws on the camera, so that's great. The more we get, the better. I appreciate it. So let me get, if I'm not looking at you, I apologize because I have multiple screens going. So I'm going to be right here, but I just want to make sure, can everybody see the presentation as it is? All right, perfect. Okay. So as Candid said, I'm Brad Negrete. I'm the Director of Urgent Care and Crisis Response Program. I also oversee the CIT that Lutheran Family Services has. But tonight I want to really focus on the Crisis Response Program because, you know, it's something that a lot of people still don't know about, but it's been around since 2006. It's been available either in Dodge County, Douglas County, or Washington County for a number of years. But the one thing about it, and as I'll go through these slides, is it was, oops, sorry, it jumped for me. You know, previously the main focus was allow to give law enforcement, police officers, deputies, you know, some assistance when engaging individuals with a mental health concern, whether that be substance use or just, you know, a mental health diagnosis. As I've come in and seen there's more agencies and there's more individuals that need this service. I mean, community just has so many, you know, the crisis response team, you know, we covered Douglas, Dodge, and Washington County. Thankfully, Region 6 is the payer for that, which is great because it gives us a good rounded program for all three of those counties and individuals to engage. So like I said previously, and still, the main focus was to help law enforcement. You know, and then we added shelters, and then we kept coming on. When I was hired here 2 years ago, I said, well, who are we missing? Why are we not engaging more people? Why are we so limited just to law enforcement? Let's start building this out to help more of the community. You know, I appreciate and I love working with law enforcement. I've been doing it pretty much my entire career, but there's other agencies out there. You know, one of the things we had to look at was safety. When I send a therapist out into the community, we have to look at that safety of that therapist. I have always been going out to the community, whether it's here in Omaha or Dallas, engaging families in their home, whether under a crisis or not. But at the same time, you know, safety plays a part of it. And so we started looking, okay, who else could allow us to go out and engage that? So that's where we're looking, because right now, what we're dealing with in the climate is not everybody wants law enforcement to come out to their house, but a lot of people need a therapist or somebody to talk to, and a warm handoff per se, somebody to come in and do these assessments and send or build resources around them to hopefully be able to allow individuals to stay in their home. So my focus and the focus at LFS with this is how can we continue to build that? Building collaborations with those other agencies, schools. You know, we have some shelters. We started branching out to other ones, other community programs. You know, so that way we can go out, engage these families, still have safety by possibly having a member of that other agency there with us, but still being able to focus on the family, the kid, the adult, whomever is needed to help with that assessment. So the mobile crisis team is made up of a wide variety of individuals. The other thing is, you know, we're 24/7, 365. Doesn't matter. When COVID hit, we didn't stop. We continue to go out to people's homes. We continue to go to Burger King to meet people in the community. It didn't matter. We'll go to shelters. I was just down there last week assessing an individual. We'll go wherever that person is within Douglas, Dodge, or Washington County because we know that they need help. The thing is the mobile crisis team, it's activated still by officers, as you can see there, but it's also activated by a number of different agencies that we'll go through in a little bit. So as it says, the mobile crisis team, we're there 24/7, 365. We're made up, we have a peer support specialist as well in our program. We're all therapists. And then we also are just getting started, a co-responder in the Douglas County Sheriff's Office. Literally just had him turn in his background check so we can get that program up and going. So we're looking at how can we engage these people? How can we engage people just to help them when they are, as you can see on the side, if they're depressed, if they're having suicidal thoughts, if they're aggressive, you know, intoxicated, you know, just a family disturbance, domestic violence. It doesn't matter if there's something going on. that an officer or whomever else needs that's there that has access to our team, we ask them to call us, and we tell them to call us as soon as possible. So that way we can start building a rapport quickly to help individuals hopefully avoid either an arrest, an unnecessary hospitalization, or just anything else that could come of it. So we try to do our best to make sure people stay in the community. So what we do, and to give you an idea, we'll do a rundown of what happens. So initially when somebody calls, the basic information is gathered. We have a hotline that takes the call, from whoever is needing. If they're from that resource list that's approved to call our crisis line, we'll gather the information as it says, get the phone call, because we want to make sure that if we get disconnected to the office or whomever else is out there, we can get back in touch with them. We find out the address, the consumer's name, and we start rolling. Once we get to the scene, as it says, it takes about 20 minutes. That's on average. Now that's on average with both adding in the numbers from going out to Dodge County as well as Washington County. So once we're in the metro area, it's lower than that, because we know speed is part of it when dealing with law enforcement and other agencies. You want to get there as quickly as possible and start doing this. So once we get on the scene, we're going to consult with whomever called, but then we're also going to immediately turn our attention to the individual that needs the help. There's many times we'll sit down next to them. We're coming out plain clothes, where there's no indication that we're a therapist, no indication right now that we work with law enforcement. We're just a bunch of people coming out with our badges, name badge, not a badge, but just that information. And then we sit down and we talk with them. We want to figure out what's going on, and we do a wide variety of assessments. Our assessment right now is about 4.5 pages. And here's what's really created on there. We're looking for that basic information. We're wanting to try to find some of the mental health history, the current symptoms, what's going on. Obviously, if there's substances being used or in the person's system, we want to at least see and assess for that. The one thing that we mention when I say safety is we want to make sure that whomever it is, law enforcement or somebody from another agency, remains there so we can have that safety piece. But if we're trying to transition to, if we don't need somebody else there, then we make sure to try to let them go or to deal with something else. So that way we can still focus on the consumer, him or herself, and gathering that, because we know sometimes having that extra person around might limit some of the engagements or the rapport that we're trying to build. So again, back to our assessments, we're looking at safety screening. We're always looking for homicidal, suicidal, and just ability to care for themselves, because we got to make sure that once, is that the reason why we're there? Is it because they may have a hoarding tendency? Is it that they just lack basic resources, and because of that, they're in a crisis of some kind? So we're looking at all that. The criminal history, a support system, that really comes into play immensely once we're looking for safety planning. How can we ensure this person gets their needs addressed if for some reason they lose contact with us or they stop engaging us? So we try to pull in other individuals to gather information, because let's be honest, sometimes individuals that are having a crisis, they can't share a lot of information. They may not know it. Their mental illness may be overwhelming them at the time, but they at least have a telephone number so we can talk with somebody else to get some collateral information. Then obviously we're going to look if there is some homicidal, suicidal thinking, looking at risk factors and lethal means. And then overall, like I said, the biggest thing is we're looking at the needs. What does this person need right now, but also into the future? So as we're sitting there going through this paperwork, and it's not just a random questions, we've structured it so it really flows like just a regular, hey, how you doing today? You doing all right? So what's your name? It's not that we're trying to delve deep, but it just flows. And a lot of our therapists have a lot of practice doing this, because not only do we take the crisis calls, we also do therapy as well. And again, since we're dealing with a lot of law enforcement, our goal is to keep our assessments as quickly as possible. We try for 30 minutes. When it comes to other agencies that we're going, if we're going to the shelter, if we're going with juvenile probation or another agency, we'll use whatever time we have to do a really thorough assessment. But when it's with law enforcement, we try to speed it up a little bit because we know there are so many calls. So we try to be appropriate to not only the consumer's time, but also the agencies that's called us there. I got a quick trigger finger tonight, I tell you. Holy Moses. All right. All right, so continue. You know, the one thing is that we like to use evidence-based. You know, we use a lot of these things, the mental status exam. We also have what's called the Columbia Suicide Scale. And I apologize if you can't read it that well, because even on the cards, we hand these cards out to officers during training. And we train them on this to look at, you know, some of the questions that ask. This is a really brief assessment. And it talks about suicide. A lot of individuals have a really hard time asking those questions about suicide or homicide. But many times when individuals are in a crisis, they will completely and easily say if they are thinking one way or the other. And so this card and this scale really helps it make it be easy on an individual, especially law enforcement or people that are not normally asking these questions, to just answer them and decide which steps to go. Now I can, hopefully in this slide, you can see there's some yellow, there's some orange, and there's some red. You know, the yellow ones are obviously questions. You want to pay attention to it, see what's going on. You might want to have somebody else come out, the mobile crisis team come out. And then as you get down to the orange and the red, that's really when we've highlighted it in there saying, you definitely want to call somebody else out to get that assessment going, because there's more going on than just what you might be able to handle with. So it's like, hey, call crisis response, call the co-responders, get them moving so that way they can help you out, because we all know a number of our law enforcement officers, although they get mental health training in the academy, they could always benefit from some extra ones. So again, if you can't see this here, I would try to blow it up, but then I'd probably end up messing up my screen. So let's just say the first question really is have you wished or you were dead or wished you could go to sleep without waking up? You know, and if it's this scale asks, you know, lifetime wise, which is that first two yes, no columns, and then the last month or the last two columns. So obviously if someone says no, that's why it's white. But if they said yes, that's why it's yellow. And it starts saying when you go down here at the bottom, and it's hard to read even worse, the response to the answer, number one, you know, call the crisis number, you know, the crisis hotline. And then as you keep going down, the question two is, have you actually had thoughts of killing yourself? You know, and we write it, and it's been written this way so that way people just read it. You know, and it makes it easier just to read it and just simply state it as it is, to not sugarcoat it, because and not to him all around it. It is what it is. If the person, as I've been doing this for over 20 years, they're honest. If they're in a crisis, they're going to share and they're going to tell you. It might be a little, you might have to repeat it or say it differently. What I've seen is individuals will definitely answer that question. And so like it says, is as they're yellow, it starts becoming a little more urgent to get the mobile crisis team out there, or this individual just needs some help. So obviously, like it says here, you know, we're going to look at the suicide risk factors. You know, substance abuse, that's a huge one. We're also listening to see if somebody may have passed away recently affecting this person. We're looking for elderly white males, and many times that's one of the highest rates of suicide. A lot of people aren't really aware that elderly white males, their percentage of committing, dying by suicide is much higher than a lot of people. So we're also looking at family history. Do you have a sibling or a spouse or a parent that's you know, been suicidal, homicidal, anything of that nature? We're also looking for that command hallucinations, because many times individuals, you know, unfortunately the voices in their head are telling them to. And so we're looking for all these things. I would read them all, but we're going to skip it now that my hand hit my button. So that works. But the other thing is we're going to look at the disposition. And like I said before, we're always looking for the best means for the person. You know, we're always looking for, how can we best fit this person to get them the resources they need without affecting their daily life. I mean, that's what it truly comes down to is, can this person, in my mind, like I always say, is can this person live at their house without having to go to a hospital, without having to be voluntarily or non-voluntarily taken to either a detox center or a psychiatric center. So we're always looking for how we can plan something and finding ways to help somebody out. So like it says, the next steps is the EPC, the Emergency Protective Custody, where law enforcement has the ability to take somebody into custody to transport them to either a mental health facility, a hospital, emergency room, whatever. The CPC is the Civil Protective Custody, and this deals more with officers being able to take somebody to a detox facility. Just for that safety piece, if somebody appears to be so intoxicated that leaving them alone would be a safety issue, they have the ability to take somebody to a detox center. And again, those are the two last ones we look at because we want to have things voluntary or even staying in their home. And so we're looking for that. Will that person voluntarily go to the hospital? So an EPC is not necessary. Many times officers will still give them a ride. I mean, but we're also looking, hey, is there a friend, a family member? Because then during the daytime, our mobile crisis team can follow. At the nighttime, when we're using our mobile crisis team on-call team, they'll call the hospital that the officer's transporting them to, or wherever their friend or family member is taking them, and just call them and say, here's what's coming. Because we want to make sure the ERs are aware of what's going on, as well as why we've made a recommendation or why this person now is voluntarily coming or by way of EPC. So then we're looking also at maybe they need medical issues. I mean, a lot of people, and it really struck me because when my mom was more recently, urinary tract infections cause a great deal of hallucination and delusions for individuals that are of a certain of elderly. And so it was really interesting to see how my mom's medical issue truly affected her whole mental health. And a lot of people don't pay attention to that. And so that's something we really look at, to look at that age of somebody and see, could this be as a result of something medical? And then obviously we're going to do safety planning, which we'll talk about in a little bit, but we're going to look at those links to resources. We really want to set people up for success. We want to walk away from that person's home and saying, if we do A, B, and C, we're doing the best that we can. We are setting this person up to have success, not only in this moment when hopefully we've been able to get some stabilization, but also the next day. And that's where it talks to, I'm going to skip the one part, but the bottom bullet here is we follow up with individuals the next day. So when our mobile crisis team goes out, if we decide that somebody should remain at home, we're calling them within 24 hours. We're looking at, we're not just stopping there. We want to know, how's it going today? Are things getting better? Are they getting worse? Do we need to come back out and meet with you again? Do we need to schedule, more services to help? Did you call the resources that we had set up for you? Did they call you back? We really want to make sure that after we do it, it's not just one touch and then we go away. It's one touch, then we follow up, because we also do, like it says here, the 24-hour follow-up. But we also, even if they drop off our radar, they don't want our services in the means at that time, we're going to follow back up with them again in 30 days, just do a call and say, hey, how are things going? Because we want multiple touches and multiple opportunities, because we could have done such a great job that for those 24 hours, those couple of weeks after our engagement, they were perfectly fine. But then after that, say 2 or 3 weeks after it, something happened, but it wasn't a true crisis, but it was starting to build. And so we reach back out on that 30-day to say, hey, how can we help? So that's one of our things that we've always done and continue to try to build, is that follow-up with consumers. Like I said before, with our dispositions, we're trying to avoid hospitalizations in jail, especially jail, because we know our criminal justice settings, they have plenty of individuals that are there. I think it's 20 to 25% have some kind of a mental illness. Probably about, of that, maybe 10 or so might be of a severe and persistent. So we want to keep diverting individuals to the right setting, whether that be to a hospital or just those community services, because we try to do, again, the wrap around services. All right, so as we get to safety planning, this is where really the meat and the potatoes of this comes, is when you're getting somebody that is calling 911, you know, something's going on, that there's some unmet needs, some things that need to be taken care of. So we look at what are those? What are those mitigating factors that can help things get better? What are the risk factors causing things to get worse? And so we start looking at that, and we have a sheet that specifically talks all about, you know, who can we call? Who can they call? What resources do they have? What are they lacking? What do they want? You know, but at the same time, we're also looking at the mitigation of if they have means, the lethal means. And, you know, we come out, and these are pictures of actually the medication lockbox, the orange box there, but we also have gun triggered locks, and we also have gun safes, as you can see in the little black one. So if we go out to the scene and somebody says, hey, you know, I do have a gun, and they may not have any friends that can hold on to it for them, we're looking at how can we mitigate that time of a possible suicidal or homicidal thought to delay it, because we found if we can delay some of those, it helps. You know, as a lot of people know, suicidality is fluid. You know, we can assist them through that crisis at the moment, but it might come back, but it might go away. So we offer those delays. I know one of the best delay I've seen was somebody, you know, their means of harming themselves was to overdose on some medication. They had a bottle, and they said, you know, if I ever do get that bad, I'm going to take that bottle of medication. So one of the therapists, being really creative, filled this orange container with water, and since the pill bottle was sealed and it was, you know, had a really tight seal, put it in the water and then stuck it in the freezer. So it took that person, you know, if they first had to unlock it, get it out of their freezer, unlock it, but then they had to thaw out that ice that surrounded it to be able to get to those pills. And so our goal was, since we couldn't take the pills, the person didn't want us to take them or give them to somebody else, we just had to find those ways of decreasing opportunity. And so that was one of the most interesting stories. And I think the person even said it was after about 6 or 7 months, they still left them in there. And then finally they just threw it all out because they no longer had that desire, because we had some engagements. So also we're going to look at coping strategy. How can we not only deal with this concern that's happening, what all is going on, but also how do we continue it after we're gone? So we look at, you know, coping strategies, you know, the delays of medication, you know, breathing techniques, you name it, we run over it depending on that person, because we really want to become, and really are, client-centered, where you let us know what we can do. It's not one of those that just because we're the professionals, every person has their own story. Every person knows themselves well enough to say, if we're going to leave somebody at home, how can we help you? But what have you done in the past? What has worked? What hasn't worked? And if somebody doesn't have anything, let's start at the basics and go from there. And again, we're going to look at, hey, if we're leaving somebody in their home, we're going to wrap resources around them, we still encourage them to call 911. You know, or if it's not 911 and they feel that's not that concerning, we'll give them our therapist will give them their number and say, just call me. So we work on these touch points to make sure people are getting their needs met, and we're linked to resources for that longer stability. So this is the great piece about going out on calls. The calls are that exciting piece, that scary piece. I think every time we hire a therapist, you know, it's one of those, well, what if I do bad the first time? What, you know, and we do a lot of training. We take as somebody comes in new, we'll have them go with a therapist that's been doing this for a while, so they feel more comfortable. But sooner or later, after a number of calls, you jump in. We're always available, as supervisors are available to be called and to hear, but that's usually that first one, everybody's nervous, but then they realize, well, I've kind of already been doing a lot of this in an office in my practicum student, it's just a different setting. So it's getting people's minds to think, hey, you've been doing this. you're comfortable with it. You're just now maybe standing in front of Burger King out in the street with a police officer and an individual, or a probation officer and an individual. It's just different settings. So teaching people those to get past that is a big part, but they do, and they do well. I mean, that's the one thing I love about our staff is they're very client-centered. They want to focus not on what's going on, but we all know that so many individuals have trauma. So we look at that trauma-focused care and seeing and keeping that in our minds as we're engaging individuals. The language we use, their body stances, everything about it is don't cause and don't trigger more trauma. Be there to be that helper. So like I says, we continue to do that safety plan. We link people to resources and we go from there. Again, I always keep coming back to divert because a lot of individuals may not think about if this person goes to the hospital, they could possibly be there 2 to 3 days. How many, individuals really can miss 2 or 3 days without possibly talking to their boss without getting fired? That in my mind, every time is we're always looking to divert is because our goal is not to make things worse. The easy, answer if somebody wanted to be that way to tell an officer, yeah, they need to go to the hospital. But when it takes that harder work, that client, that consumer as well as therapist to look at it and say, but if we do that and somebody does go to the hospital, how could this affect them? So that's where we're also looking at not causing any more problems. And a lot of people don't realize that. So that's the nice thing that we teach our therapists is don't focus just on today, focus on how this is going to affect this person's life. All right, so some of the resources that we have, and this I really love this about our program, and I'm very thankful for the region for allowing us to have it this way, is once somebody engages our mobile crisis team, after that, like I talked about, that follow-up, they are provided 90 days of stabilization. So that means coming in and doing outpatient therapy, having resources, having the therapist free for 90 days, no matter what. Doesn't matter. We've treated doctors. We've had some homes that are just amazing that we've walked into and had that person come in and go through our 90-day stabilization program because that's what they needed and that's what they felt comfortable with. And, they didn't want to have to claim it, on their insurance because a lot of times that could have a detrimental effect. So of our 90-day stabilization program, we do post-crisis therapy. Whatever the person needs. I can't reiterate it enough is if that individual comes in and they want to have therapy on Monday and then Wednesday and Friday, if that's what they need, that's what they get. We also look at other types of therapy. We look at EMDR therapy, where that's the eye movement therapy that helps individuals. It's really good for those that are trauma-based. We also make referrals in-house. I mean, majority of these are going to be in-house. Medication management. A lot of our individuals that we run into is they just ran out of medication and didn't know how to get any more. Wasn't aware of it. So what we're looking at when we're doing these post-crisis therapy services is what else do they need? Again, we do case management. We're therapists and case managers and social workers all at the same time. That's the key point is what resource do we have that can help this individual? And again, if we can't find something in-house that helps individuals, we'll go outside. We have no problem looking at other resources in the area to best fit the needs of this individual. I mean, that's the one thing that we keep harping on and we tell everybody, you can't find it here, go somewhere else. A lot of our individuals we engage, we have them engage with, the Salvation Army, their emergency community support program. That's where they're meeting somebody within a day or two to get other resources in addition to what we're trying to do, because not everybody wants therapy. I'm sorry, just because they may need it doesn't mean they're ready for it. And so all we can do is offer something, but if it's not therapy, then what's next? And so that's where it comes to that safety plan as far as, other resources. The other great thing, and I wish that the state of Nebraska had, and especially here in Omaha, is part of our program is a peer support specialist. And this is Michelle Gertis. She just started a few months ago, and she's amazing. She has that lived experience. She's gone through her own mental illness, her substance abuse work, and she's not afraid to share that with somebody. And that's the best part about Michelle is that she is a very blunt person. She says it as it is, tells you what she thinks, but does it in a very trauma-informed manner. I mean, sometimes we're like, Michelle, we can't be too blunt to individuals. They have stages of change, so we got to stay within that and work with them. But she does a great job of feeling and building rapport with individuals. The other great thing about it is she's our link with Omaha Police Department. So although she works with LFS, she's one of my employees. She also spends time with Omaha Police Department. She does a lot of the outreach and follow up from the co-responders. She goes with the co-responders out to some of those proactive calls to help individuals that maybe call a 911 a lot when it's a mental health concern or a resource concern, but not so much a 911 crime concern. We'll go with it that way. She's also a resource for law enforcement. A lot of the officers will talk with her to get her perspective. But then she helps with CIT and gives, what it's like for her to engage an officer. I mean, because a lot of times, they need that perspective as well. And it's an open perspective because she's pretty blunt with officers as well, which is quite nice because sometimes to reach an officer, you got to be pretty blunt. And she's that way. So having a peer support specialist to help us with everything, it's been great. And also having somebody from OPD with us only helps because then we can have some communication in lines through her that benefits the individuals, but that Omaha Police see, but also some people that we work with. So there'll be times that maybe a call might have came in and Omaha Police Department doesn't think it's really a 911. They can contact Michelle, and Michelle and I might go to that person's house, or Michelle and the team leader of the crisis response program. So we're looking at how can we engage as well and get the most out of Michelle and her skills. I want to continue to grow peer support within our programs, but throughout everywhere, because I think it's nice to have that perspective, because I've have families that's gone through criminal justice or mental health things, but I personally haven't. So being able to talk with her a little bit more and say, how does this feel? How do you relate to individuals through your eyes? If I did something, a lot of times I'll go back to her and be like, did that make sense? Was I off there? And she's like, no, but you could maybe say it better this way. And so it's great to have somebody with that lived experience to be part of our team as well. All right, so why crisis response? Obviously, we're trying to reduce those law enforcement calls. That's one great thing about the co-responder program with OPD. And then as we establish ours with Douglas County Sheriff's Offices, we're trying to be more proactive with individuals because we can find out who are those individuals that are calling quite often that may not need a law enforcement officer to go out there. That you might need 2 therapists to go out there. You might just need somebody to talk to, somebody to do a warm handoff from one program to another. But that's the goal of crisis response and our co-responders as well, is to reduce those calls, but also to be proactive in those calls. That's one thing the Omaha Police Department does. They have their core team, and that's where they're sending out an officer and one of the co-responders to somebody's home to stay ahead of that possible crisis that could be looming. Also crisis response, I mean, I think is a huge portion of it. We're linking people to needed resources. It's amazing that Omaha is a very resource-rich city, but a lot of people just have the hardest times figuring out, where do I go for these resources? How do I engage them? And especially the one thing that I've noticed is if somebody is mentally ill, it might not be so easy to engage the services. And it might be certain times you have to, and they just, transportation could be an issue. There could be a myriad of issues that are going on. So we're looking at how to connect them to the needed resources. A lot of times it's a warm handoff to where we'll call them with them, whether that's in our therapy session or, on the crisis call itself. Again, we provide that input for the dispositions to the officers or whomever else may be there. The other part is we're trying to keep them safe. A lot of times people worry about their safety when they see a mentally ill person, but at the same time, we're looking at the safety of that person. We look at it as we want to keep everybody safe in the community. As I said repeatedly now, we're trying to divert individuals from hospital or jail. And like I said, we want them to stay in the community. More importantly, we want them to have some crisis stabilization, but being able to build skills so that way, if something comes down the pipe a little bit later, they're able to handle those and then look for resources or contact somebody to be able to handle that crisis, because we know a lot of individuals that call, they might call several more times because their resources or their needs aren't being met. And so we understand that. So we're always looking at how can we, educate individuals to better handle situations. As you can see, one of the stats here from some of the data that we keep, 87% of the individuals we surveyed, they said, and they're better able to manage a crisis because they had engagement with the crisis response therapist. So for me, I'm always looking at what's next. And what's next for me is I want to get in with schools. Right now, a lot of our Omaha public schools, the secondary schools as well as the high schools, they have what's a school resource officer or an SRO there. So the SRO, because they're law enforcement, they have access to our co-responder program, but also crisis response. But a lot of the elementary schools don't. And so we're working with them to say, hey, if something happens, let us be another resource to help you all with the individuals, because we can work with them not only at the school, but then we can poll and talk with parents and work with them when they're at home. So we get that whole program or that whole dynamic that's going on, not just the behaviors that are going on at school. As I mentioned before, is looking at other community and county agencies that need this. Juvenile probation was one that jumped out in my head immediately. But then from engaging them, the home program, which is, a home on monitoring. So it's an ankle bracelet for juveniles. So we're looking there, but we're also looking who else. I've been contacted by many individuals now since we've opened this up to help, because we're all seeing a lot of crises occur, mental health crises occurring, and we want to be able to help. And so I'm trying to keep my staff busy. I would love to keep building. And that's one of the things that, I've talked about, with the presentation with our county commissioners as well, is what about a mobile crisis team that's for just the community? We have hotlines out there. Why not have them triage it? And so that way I can have a team of maybe 10 therapists working all the time, or at least during the day, so that people can call and there's no need to worry about safety of law enforcement having to come out or anybody. It's if the call is appropriate, then we just send 2 therapists out. There's been a lot of talk about the Cahoots program. Maybe it's a therapist and an EMT. There's a ton of programs out there like that. And I think that's something that we need to look at as well. And additionally, moving forward is we want to look at locating therapists to decrease that response time. Like I said, I hate having it being 20 minutes average for Douglas, Dodge, and Washington. I could break it down even more, but I'd much rather have more therapists, because I know Dodge County, Fremont needs therapists out there as well. And we could get more buy-in. Actually, Dodge County was the first county that had mobile crisis. That's where it all started. And it moved to Douglas County after that. So we're always looking, what's next? How can we keep building? Do we build another array of services, or do we keep expanding the crisis response program? I've also been going to be meeting with Omaha Fire, because Omaha Fire Department, the PES, that UNMC, that's they probably take more people to the ER than what law enforcement does. I learned that last meeting we had, is looking at the numbers, is that it's significant that fire, whether it be medical or not, but that's the ones that are coming through the ER and the PES the most compared to law enforcement, which was interesting. So that's where I was like, when I heard that, it's like, well, we need to talk to OFD and see what we can do to help them as well. So I'm constantly, and that's what makes my supervisor laugh as well as my staff, is that what's happening now has happened. What's next? And that's what we're always looking for. That's where we're looking for the ARPA money that Douglas County has and the city of Omaha has. How can we build more mental health programs to help individuals, whether it's expanding what we have now or starting something completely different? That's kind of my goal, and that's what I love doing. So, all right, so that's this last slide here is just our contact information. So this is obviously me. You can see the big smile, the tilted head. Eve Durbo is our clinical supervisor, and then also we have Michelle Gertis, our peer support specialist. So by all means, candidate will have these slides, and feel free to contact any of us. We'll always be able to help out as needed and answer many questions. So as I take my drink of water, you know what, I'm going to stop sharing for just a second. And if any of you have any questions, I'll be more than happy to go over some of them about crisis response right now, and then we can delve into CIT a little bit.
We do have some things in the chat box. I'm not sure if they pertain. Well, they should probably pertain to what we're talking about right now. Joanna asks, what stats do you have with OPD, if any?
All right. So OPD is not part of us. They're their own entity, they're co-responder ones, but we work with them, and I see a number of their stats. Actually, a number of their co-responders are part of the mobile crisis team, to be quite honest. So they don't really share the numbers, but I know just from talking to a couple of deputy chiefs that there's probably they're going through about 400 calls a month, the co-responders there. And the co-responders there's one therapist at each precinct. We used to have a grant together. The co-responder program was a shared grant, but it benefited OPD as well as the therapists that have it to themselves, because it also gave the therapists, they became city employees, so then they could start driving city cars instead of their own, and then a myriad of other things as well. Cool. So I don't have a ton of stats from OPD that are current.
Totally understandable. A follow-up to that is, how comfortable is OPD to use your program compared to other counties nearby that you work with?
I will say Omaha Police Department is the highest utilizer of our program. Out of the calls that we get, and I'm trying to get even more, we fluctuate between 40 and I think the highest is 70 a month. I'm wanting to get much closer to 80 to 90. I'd love to see 2 to 3 calls a day. So officers are using us, but other agencies. But since it has been locked down for so much, getting that buy-in, it's new. And so as things are new, people aren't using. The other thing is officers, retire. So COVID really hurt, because we used to do a lot of roll call trainings, not just OPD, but, within Douglas County Sheriff's Department, Dodge up in Fremont, Washington County, we do roll calls for them as well, so they could understand who we are. We had a grant with the region, so where we could actually give a number of agencies iPads, so that way we could do telehealth to make it quicker, especially Fremont, Blair, and Washington County. They have iPads, so they can contact us, and the therapist can engage immediately because they have the iPad on the other side, so we can do that.
Very cool. Well, thank you for that answer. Bridget, would you like me to read your question for you?
No, I hopped on because I was like, I can ask my question since it's been long.
I was just reading that.
So I work remotely for an organization in DC. I used to live there. Thankfully, going to live in Omaha, close to my family, but we do all the crisis intervention work in DC for domestic violence, and kind of operate similarly to mental health crisis response, in that we do on-scene calls and are focused on kind of immediate services after someone has called 911 or experienced a violent incident. And I don't know whether you would have the answer to this, but I always wondered what kind of the protocol for crisis response for domestic violence is. I would assume there's crossover with the kinds of calls that you do. And I just wondered whether you could speak to essentially what crisis intervention looks like for domestic violence calls.
In the beginning, we look at it, and it's might be jaded to say it, but it's all the same. It's a call, it's a crisis. We're going out, assessing what's going on, and seeing how can we help this individual. That's one of the additional agencies that we engaged was the domestic violence shelters up in Fremont and Blair. And so we opened that up, and we literally just did the assessment, see what we can do, what resources are available, what's the need, and we just go from there. So
I have a question.
Yes, ma'am.
Are you guys part of the Region 6
Yes, Region 6 is our main funder. Yes.
Okay,
Yes, ma'am.
I thought so. The other question I
Yep.
have is can you give Candace your PowerPoint you just did where we can have that information?
I can send a follow-up email after this or
Oh, you
tomorrow.
have that already, Candace?
Yes,
Oh, okay,
definitely.
that would be great. I'd appreciate that.
Absolutely.
And okay, the other thing I wanted to say, Brad, was I had a conversation about 5 years ago with Chief Smarter, and we talked about, and this was before that I considered reimagine public safety around, the police department, going out on calls and not being equipped, when it's a mental health call. And so he was letting me know at that time that, yeah, they do that very poorly, and that he was, really wanting to do things a lot better. And I was telling him what he needed was to actually to partner with the agencies that do mental health and let them accompany, the mental health calls, before the police go out and mess it up and everything. And so that is why you see therapists now, in the police departments, because of the fact that he realized that that was something he needed to do.
Definitely, definitely. I would say, it's it's a great thing. I mean, having the co-responders, I mean, it was a great transition for her to going over there. I know, Chief Schmatter, as well as former chiefs and Deputy Chief Bain right now, that the co-responder program falls under Deputy Chief Bain, and she is a very big advocate for mental health and getting more therapists, getting, as they say, the right people to the right call.
That's right. That's
And
right.
that's, like I said, is LFS and OPD shared the co-responder program for a number of years, and then it split off. I know we're going there. I have a number of grants out right now to do a co-responder program up in Fremont, as well as Washington County. As I mentioned, we have our Douglas County co-responder getting ready to start as well. So a lot of what you and many others have said, people are paying attention to and being able to get more therapists in there. It's now just, how do we continue it, and how do we keep building from there to make sure that, as you will say, law enforcement doesn't mess it up. But that's also where we come into play with teaching law enforcement, which is the second half of what I'll talk about is, they're increasing their hours of training, mental health first aid in the academies. We've also had the Sarpy Douglas County Academy come through CIT to try that, to try something new. So there's a lot of different things going on to really get mental health in law enforcement. And then also looking at what are some of the tactics we can do to better help law enforcement when they engage them without a therapist. But then what can we do on the back end to avoid them even getting the call?
Great. Thank you for that answer. Palestine, do you have anything else you'd like to ask? Or did that answer your question?
I can't hardly hear you, Candace.
Oh, sorry. I was just asking if that answered your question.
Oh, very much so.
Okay.
As he said, I know Ms. Bain very well. She does a lot of training, and so I know her well.
Great. And Bridget, I just want to make sure your questions were answered as well.
Yes, yes, it was.
Okay.
Yeah, mine was answered as well.
Okay. Just want to make
I
sure.
have one more though. I know we're
Yeah.
over. Can I still ask it?
You're
Okay.
good.
That's
I
fine.
might have missed this at the beginning of the presentation because I was late, so I'm sorry. But I mean, I'm sure like many of us, like I have had personal experience calling someone calling 911 for a mental health crisis for one of my family members. And the officers that came out were really great. I have nothing but good things to say about the way they responded. But what was surprising to me in talking to them was that they said that the mobile crisis through LFS was only available Monday through Friday, 9 to 5. And I'm sure that's not when the majority of mental health crises occur. And I wondered,
That's right.
I wondered if you could speak to that scheduling. Like, is that something that like could even like granularly be advocated for like within the city budget for police? Again, I don't know how the funding for it all works, but that to me struck me as probably an access issue along with a whole lot of other things for in terms of like how effective and accessible the mobile crisis stuff is.
So the one thing I educate people on is there is that difference between the mobile crisis team, because the mobile crisis team through Lutheran Family Services, and this is why I say COVID really hurt, because we couldn't do a lot of the roll call trainings to get to every officer and said, we're 24/7, 365. Here's a blue card. Anytime, anytime they want us, they have access to us. So those agencies that we give the access to and the region okays, it's 24/7, 365.
Good.
The thing that's different is a lot of times officers will see crisis response and co-responders as the same thing because we're therapists coming out. Now the co-responders right now, they're a little more limited, more that daytime shift. I know when we created it, we asked every therapist to be available 1 or 2 nights a week to go a little bit deeper to 7 o'clock. 6 or 7 was the latest that we had them because we still had mobile crisis. So they had access to it. But no, that's exactly where we're trying to get through again and do roll call trainings and tell people no. And I have stacks upon stacks of these little blue cards with the hotline number that they can call. Because when somebody calls it, say Bridget, you try calling that number, the person that answers is going to be like, well, who are you with? And then if they, you're not one of the agencies, they're going to be like, well, here's the hotline you can talk to. You can't activate mobile crisis. But if an officer would call and say, yeah, I'm Officer Jones from Omaha Police Department, whomever, boom, they're getting transitioned on to the therapist, warm handoff, figuring out what's going on and getting out there. So it's one of those things that's been frustrating because sometimes we get lumped in because the co-responder came out of us. And it's just all those therapists going out there with law enforcement and who's doing what's going on. So sometimes it does get mixed up, but that's where we really like engaging law enforcement. And we'll talk a little bit more about that with CIT here in a second, to train them on this is who we are. This is what we do. Yeah, we're a little different. You use the phone, not your radio to call us.
Yeah.
But we're still definitely there for you.
That makes sense. I totally get that because we have the same model with the work I do in DC. So yeah,
Perfect.
get it.
Awesome. We have
What else? These are all great questions. I need like 2 more. Marlene looks like she has one over there.
Let's see here. Did I miss that one?
No, she just has a look on her face.
Oh, okay. Do you have a question, Marlene?
You're muted, Marlene.
Sorry, yeah, you're muted.
Well, it was a little confusing how these agencies are interacting and who's coordinating all of this, I guess. Am I to understand the mobile crisis team is through family service, and then there's also therapists with the police department?
Yes, ma'am. You are right.
So is this duplication, or how is, I guess I missed the beginning in terms of how this is coordinated in case somebody out in the community has a crisis, something's happening, they call 911. How does 911 operators know who do we call for what.
Well, and that's the great thing. That's the nice thing, is because, yes, it is duplication of services because we want overlap, because there are so many calls. There easily should be more calls than what's being answered. We know that there's, just looking at some data, probably about 600, maybe 700 calls a month that Omaha Police Department or 911 gets that has some mental health component of it. As I alluded to earlier, there's 400 of them are getting caught by the co-responder program. Again, the mobile crisis team is through Lutheran Family Services, like you said. The co-responder program is through Omaha Police Department. So the police have easier access to the co-responders because the co-responders are literally embedded in their precinct. The mobile crisis team, we do a dual role. So we do crisis calls in the day, but we also do that 90-day therapy piece that I mentioned as well. In addition to that, so we're 24/7. So we have on-call therapists. So outside of those co-responder hours, or even during the co-responder hours, anybody can, if they call 911, say, I want a CIT trained officer. This is a mental health thing. I would like a therapist to be contacted, to be brought along, whatever, because that gets two things done. Is a co-responder could be free at that moment. They're going to hear that and they're going to radio in and say, okay, I can go to it. The other thing is what co-responders are really good at is if they're in the middle of a call and they hear that, they'll advise that officer or dispatch to call mobile crisis. So that way we really back each other up during the day, and then overnight and weekends, it's on mobile crisis teams through Lutheran Family Services.
Okay. That helps a lot. And then did I understand that mobile crisis team is funded by Region 6? And then co-responders is with the police department through taxes. Is that the funding for these programs? Where did all the money pouring into this state for mental health go that we can expand these programs and do more coordinating with intense emergency rooms and really getting everybody together to get this better together to catch these people before they're shooting up the city, before they're committing suicide, because of all this mental health crisis that really our state is in and hasn't done enough money, put enough money into doing something about it, I guess, is where because I'm a retired nurse, and mental health in our state and our communities has been so poorly funded and managed.
Well, again, like you said, yes, our
So
program.
we are starting, it sounds like, to do something about it.
Yes, ma'am. Yes, ma'am. It's been great to see, and you know, our funding for the mobile crisis team is from the region. And our funding hasn't gone down. In fact, the crisis response has either stayed the same or gone up in the last couple of years.
Good.
The funding for the co-responder is some through the city. The city has some, but also through a grant with the Behavioral Health Support Foundation. So that's how we got it started, was with the grant money. And then the transition was going to take a little bit longer, but now the city has really stepped up and said, let's make these individuals part of the city itself and make it city employees, so that way they can benefit from being with their coworkers. So I know I've had meetings with other individuals, both at the city level as well as the county level, to discuss, you know, funding. You know, I mentioned a program that I'd love to see, another array of services. So that is something that's really good. And I know even Commissioner Borgeson recently said it. That's one of her focuses, mental health. And I've talked with her and other commissioners about how can we continue to build? How can we get a cahoots or another program, or broaden the array of services? How can I have more staff members to get more agencies to be able to contact us directly instead of just a certain amount? So this is the best time I've seen, been doing mental health and criminal justice, that I've ever seen. The funding's been there both at a federal level, state, and then through donors. I mean, it's been pretty good for a lot of the programs that we're trying to get started or run.
Do you think the George Floyd shooting and some of the protesting from Black Lives Matter for changes with not to defund the police, but to focus money, refocus some of the money and expand mental health programs, has that movement helped any?
I think all those movements have helped bring the attention to where it needed to be. You know, a lot of times, you know, and it's sad, but it usually is as a result of something negative. Hopefully something positive comes out of it.
Right.
And this is what I see right now, is that more attention is being brought. COVID, I mean, one of the things of COVID has really brought the awareness of mental health. You know, being isolated, that's been so hard on individuals. The stigma part of having a mental health diagnosis or a mental illness is now decreasing because you start seeing a lot more. I mean, Simone Biles, one of the best, you know, it says, I didn't because I just wasn't right in my head. It may not have been a mental health or mental illness, but her mind played a big part of it. A number of basketball players, football players, these individuals are coming out and just being open and honest about it. And that hasn't been here before. It's been hidden for many, many years. I mean, you think about even with JFK and his sister and his dad, his father, you know, with his daughter, you know, hiding it away so it never was known. But now we know that's where so much of the federal funding way back in the day that caused the institutionalization to come from occurred. And so, I mean, these are all steps. It would have been great if Joe Kennedy would have said, my daughter has a mental health. We could have been there maybe 20 years ago doing things a little bit different, but things are where they are. So now we're just trying to see what's next. What's our next steps? How do we get funding allocated to build these programs to get people things they truly need?
Absolutely.
Well, you
So,
know,
Marlene, I'm glad I asked you if you had a question, because I knew you had some good stuff there.
That was great.
what I was going to say, Brad, when you were talking about the Kennedys, you know, that has to do with the stigma, you know, and we had a problem with that. They didn't talk about that. They hid it. And so when people start being open and honest about it, then that's when we start getting into more of behavioral health, where we could go to get resources and talk about, you know, and then have people to be able to express how they're feeling about their issues. It's where, you know, we're coming from.
Amen.
Absolutely.
You know, an honest conversation is worth $1 million in my, I mean, if you, to be able to have those honest conversations, just simply say, and having people feel comfortable in their own skin,
Right.
is huge. I don't think people, maybe not enough people really realize that in the past. I think we all have been of that mindset of what happens in your family stays in your family, but many times what happens in somebody's family affects the community. You know, and I'll say from my experience, my tragic event was my sister. She took her life and the lives of my 3 nephews. Not only did that event affect my family, it affected my brother-in-law's family. It affected the officers that had to deal with that. It's that ring effect of when you're throwing a pebble. It just keeps going. And so it all comes from one little thing. And so my family's problem caused a lot of other concerns. And so we all have to be able to be comfortable to talk about it and deal with it, find ways and plans of what's the best program? How can we find another program? If we're missing an array of service, how do we find funding to get that service here? So don't get me started. You got me going now. I'm on my soapbox. I'm ready to go. It makes me feel like I'm back in class at UNO teaching again from this morning.
Well, you know, they call this dine and discuss. So this is just fabulous. And we so appreciate that. Yeah. Wonderful.
Perfect.
Yeah.
Well, all right. Any more questions, or we can get into some CIT, because I love CIT as well.
We can.
Well, I just had one more comment. What can we do? Anybody's doors or phone numbers we should be banging on to support the programs and to expand them, or anything we can do to help?
You know what, Marlene? Let me get through these next ones, and I'm going to give you all a whole lot of homework to help me out in some programs. How's that sound?
Sounds good.
All right.
You're gonna have to.
Thanks.
Clyde, Marianne, you got a question?
Yeah, I ride the Metro Transit buses a lot, and they provide services for a lot of the mentally challenged adults. A lot of them, now these aren't people that isn't identified, but they have suffered often from childhood, because we have a problem in Omaha, of course, with that lead soil contamination. So a lot of kids had brain damage and various problems, and how we're dealing with them as adults. But anyway, like they ride the bus from the group homes to places like the adult daycare that's on Maple, about 74th. And often they'll have, or not often, but occasionally they'll have an episode. And the drivers don't know, their only response is they call dispatch and they send out a police officer. And often it's a pretty ugly scene, them trying to get that person off the bus. And do you ever work at all with the transit agency on how to deal with this? Is it really best to have the police come out and take these and deal with these people?
Well, again, we're trying to work within the limits that we're given. I think opening it up to sorry, let me close this shade. As I try to lean in here to get closer to you all and keep getting blinded. So, you know, that's one of the areas that we're looking at as well. We're looking at that moving ahead is what are the agencies that needs additional help? So knowing that there's that bus driver right there and possibly the security from, you know, the bus line, or even them calling an officer. See, that's where that officer should know right off the bat if they're being called. And this is something that we train people in, is when you're calling, make sure to say that that's a mental health concern. When you're calling, say, I want a CIT officer. When that call comes in the dispatch, letting all those key words, mental health, you know, all those behaviors, might be hearing something or seeing something that should trigger officers as well as co-responders to think this is a mental health concern. Let's engage this person the best way possible. But that you've now given me another avenue of let's look at transit police. Let's look at them. Maybe we can open that up to them as well, because I'm always game to provide services and keep my staff busy. They love going on these calls. It's one of those things that it's the excitement of the day. I mean, being able to get out there and engage. I hire people that don't want to sit behind a desk. I've taken that punishment on myself now as being the director of having to sit behind a desk. When I go to get to do a crisis call with people, it's great. That's probably the highlight of my day, is being able to know that I affected one person directly instead of, you know, the larger program as itself is I got to get my hands dirty again. I'm no longer just sitting behind a desk. So thank you, Clyde. That's a great idea. But again, like I said, is when we're making those calls, and I would say that's one thing that we can do is sharing, hey, ask for that CIT trained officer. Ask, you know, share what's going on. This might be a mental health call. This person appears to have a mental illness. This person might be talking to somebody that's not there. So that way those key phrases are coming out and people are understanding, yeah, this is a mental health call. Let's get therapists involved. Cool beans. All right. Anyone else? Okay. So I'm going to screen share and let's pray it goes well again. You have to give me some head nods and let me know that you see Rebecca Hancock in the old CIT. Here we go. All right. Can we see the CIT LFS Heartland Crisis Center? Oh, yeah. That's what I'm talking about. All right. So this is Rebecca Hancock. You know, this is her now in the middle there, but then when she was at the Sarpy County Sheriff's Department, she is our crisis intervention team coordinator. She now puts together the trainings that we do for law enforcement, you know, the 40-hour trainings, and we're going to go through those. But CIT in general, the crisis intervention training, it has some core elements. And so I wanted to just briefly touch on those real quick. There we go. So like we've been talking about the whole night is, the core elements is we want to improve the outcome of police interactions with people living with a mental illness. We want them to be able to get what they need. We want the officers to have what they need. We want individuals that engage with the officers receive what they need as well. We want to have partnerships. We want to have relationships. We don't want it to be so separate. We want to help, bring together all the agencies together. And we do a really good job of that here in Omaha for Heartland CIT. If you go to the website, heartlandcitbasically.com, you'll see on that first page all the agencies that come together. We have OPD, we have LFS, we have Community Alliance, we have Correctional City, we have our public defenders, it's just a long list of individuals that come together to put this on. For the longest time, back in, I believe, 2006, this started with Douglas County Sheriff's learning about CIT. And again, CIT came out of Memphis as a result of an officer shooting an individual. So, they went down, learned, and brought it back to Omaha, and it was all voluntary. Everybody that was on the CIT panel, was voluntary to get these trainings going. And for a number of years, that's all it was. It wasn't part of people's jobs. It was just all volunteering to get things done. Even right now, and I'll show you the 40-hour CIT training, the curriculum, our presenters are all voluntary. They come in, either it might be part of their jobs, but it's more people that just want to have that have the knowledge, that want to share the knowledge with individuals to make sure the officers that are on the street hear things and learn things that can only benefit them in the way that they deal with individuals that might have a mental illness. So again, like I said, it's not something it's been something I said repeatedly, is we're looking to divert or redirect individuals from the criminal justice or judicial system to healthcare, but appropriately, and then reducing stigma around mental health, the treatment, and then the wellness of it, because I think that's a big piece of it. It's letting people see somebody that an officer see somebody that they engaged that wasn't doing well, but with treatment that they're doing well, because it's that pre and that post that people need to see that really helps. And I got a great story, an amazing story that really was huge when it happened. So let me talk a little bit about CIT itself. So it's a 40-hour week-long training. Now, the hard part is, getting officers. Heartland CIT is the only CIT trained program in the state of Nebraska. Becky is the only certified coordinator. So that makes it a little more difficult. And then we're looking at, right now, we're only having about 4 or 5 trainings a year. So it really reduces how many officers we can get through it, because we only can do so many a year. And again, it comes down to, when you look here, we talk about medications. This is a doctor coming in, trauma, another doctor coming in, mental health with adolescents. These are all specialized, either doctors, therapists, family members, trained, like on Tuesdays when you have negotiation tactical, trained individuals coming in from Douglas County to speak to the class. So it really takes a lot to put this on. And that's our goal, is to continue to broaden it, not just here, to have more classes here in Omaha, but also to expand it within greater Nebraska. Grand Island's mentioned wanting to have a training out there to help their officers become more trained. Alliance has as well. So we're working on how can we expand the Heartland CIT to get further out, because it's hard for smaller agencies to come to Omaha. A lot of people don't realize that once you get out of the bigger cities, a lot of the sheriff's office and the law enforcement agency might be a 1 or 2 person program. So doing 40 hours of training may not be that easy, especially when you're talking about traveling, on a Sunday and then on a Saturday. So that person's gone 6 days or 7 days from being able to do the job. So it's really difficult for a lot of these smaller agencies. And that's why we're looking at building onto it. So as you can see here, this is just a brief. This is one of the older schedules that we had, is what we do in our training classes. You know, the overview of mental health, our mental illness, medications. We have doctors come in to describe the various medications that are used to train somebody. Trauma 101. I mean, that's a huge one that we like a lot of officers to pay attention to, is learning what trauma looks like. Because trauma just takes the form and the face of so many other things going on. It could be substance. It's just something that you really have to learn to understand. You know, we teach about what it looks like in adolescence, because mental health in adolescence is totally different than with adults, because their brain's still forming. Crisis planning and engagement. How do we go about that? You know, I'm not going to read through all of them, but we look at one that we really like and we've expanded on recently, is cultural competency. That went from probably an hour long. Dr. Foxall comes in and does an amazing job of doing cultural competency, but also we built out, compassion fatigue, because we understand that seeing all this takes not only a big chunk of somebody else's life. Like I mentioned, my sister's thing caused problems with other officers. So compassion fatigue is huge. And how do we keep, our law enforcement in the right state of mind and doing their jobs the best they can when they're seeing nothing but trauma day to day? We also teach active listening and de-escalation skills. We do a lot of site visits. So if you see some sites, we go to Community Alliance, Safe Harbor, the Detox Center, we go to Lasting Hope. We do a lot of these site visits so people see what it looks like for the individual to be engaging. What are the resources that officers carry in their pocket, and give that telephone number out to the individual that may not be a mental health call, but they might need a resource. Then we do, again, a ton of scenarios on Thursdays and Fridays. The afternoons is basically scenarios, because we want these officers to see what it's like for mental health, but then also to teach them, active listening and de-escalation skills, but to utilize them. So we don't want them just to learn it. We don't just want to beat them by PowerPoint. We want to beat that in their head. Don't get me wrong. We want to teach them, but then we want to see them utilize them. So have scenarios, a homeless individual. It could be a person that, we have a wide variety of them. Somebody going into a home. So we teach law enforcement what it's like for various mental illnesses that they'll run into. I mean, these are all scenarios that we've gotten from law enforcement to build these from. We also train corrections. So we have a number of them that are for corrections. Also for UNMC police. We try to curtail the training, the scenario to the agency or the individual that's coming, so that way they get some real life training that could possibly happen to them in their own day-to-day job. So again, this is the CIT, the 40-hour, this is the main one that goes on. But in addition to these, we realize this is for law enforcement mainly. Fire departments can come through it, as well as dispatch, but we are also very aware that this isn't meant for everybody. Just a regular therapist wouldn't go through this. Individuals, as yourself, it may not be the best training for you. So what we've started looking at is, what are other trainings that we can have? What are additional trainings that are needed? And one of the biggest ones that jumped out to us was a crisis intervention partner training. Instead of it being 40 hours, it's just 2 days. It's a condensed version of that information, but we also focus on specific training for if a lot of dispatchers are going to come, a lot of therapists. This literally is open to anybody. If any of you wanted to come to this, you could simply just go to the Heartland CIT website and register for it. This is where the crisis intervention partner training is really huge, because we also want to train just regular community folks to give them an idea of what it is that officers go through, but also what is it that you need to know and could only benefit the community as well. And then we have the enhanced crisis intervention team training. So it's a one-day refresher for those that have already gone through the 40-hour class. We talk about some of the main, really highlighting some of the topics that are occurring in our, society today. One year it might be a detox or fentanyl or drugs or alcohol. And the next year it could be more of a cultural diversity. I mean, it could be, just engagement in general, looking at, TBI. The traumatic brain injury is one that a lot of officers will deal with. They'll see the behaviors, but they have no idea and may never know that somebody has that traumatic brain injury causing them to act like they are. So we try to just have a number of different topics for people to learn. Then, of course, we really like to focus on youth crisis intervention, because we know a lot of our law enforcement are coming by and engaging kids. And so we want to teach that, hey, there's some different techniques. There's different ways of talking with them, coming in and being the big bad officer might not always work. So here's some other tools. Here's some other trainings to look at. So again, just going to the Heartland CIT website, seeing these, you can learn a little bit more about them, see when they're scheduled. And we're always looking to add more people into our trainings. Another thing, like I talked about, is currently, the training occurs here in Omaha. Our goal is to expand, into Greater Nebraska. I brought up Grand Island. I talked about Alliance. We're looking at grants right now to help continue this, because the problem is right now we have grants funding this program. CIT in Omaha is all grant funded and one donation. That's where after next year, that grant goes away. So the money that's paying basically to have Rebecca Hancock in this position goes away. So we're looking for grants and ways and means to keep her funded, so that way she can focus on putting on all these trainings and many more. But also we're looking for plain old donations to be able to, because when we have all these officers, we're doing these 40-hour classes, we provide lunch for them, so that way we can keep them all together and we can talk with them at lunch. We can bring resources in at lunch to discuss with them, so they're just really getting inundated with information instead of it just being 4 hours, break, go eat, 4 hours more. We try to keep them all together for that week to really get them going and to have that training. So, Marlene, that's one thing you mentioned, is what can you all do is definitely sign up for those CIP trainings. The other thing is talking with, the individuals from our city council, from our commissioners, from the region 6, region 3, whatever region you may be from, is engaging them to say, what, we want, and we believe more CIT training needs to occur. We need more officers to have this training. If it goes away in 2 years, what's next? That's the hard part is I have to keep thinking, and us on the executive committee is like, how do we keep this going? We've been asking for different donations, but at the same time, there's a little bit of limitation, for sometimes it's space alone. We've had a transition between, we had these trainings initially at Metro Community College and the North Omaha campus. Well, once COVID hit, we had to move and we went to the Croc Center in South Omaha. And then the Croc Center had something going on. So we had to move out to, the training facility for out on 132nd and L. And then now we're at Christ Community Church because they donated the space for us. So now we have a great space. They actually help us with lunch. So now we're able to, find a lunch that falls within a better cost for us, so we can afford that through the donations that we receive and keep going from there. But we're always looking for volunteers, on the scenario days. We're always looking for actors. That's one thing that we truly need is actors to help us present a certain way. If that's difficult. A lot of our therapists we're doing that. So volunteers to help act, volunteers just to be there to help shuffle people around, making sure people are going in the other area. Always looking for that kind of help. And again, I always hate to say it, but like I mentioned, the financial piece, that's the hardest piece, is because there's really not a lot of grants or funding for this. There's grants to get it started, but to continue it and to keep it going, it's usually about a 2 or 3 year grant. And then you pray some entity or agency takes it over and runs with it and keeps that that CIT coordinator on their payroll. So right now she's funded through the next 2 years, and I'm hopefully going to get another grant that'll keep her for another couple of years. But as we try to grow this, it takes money to grow things. And right now, yeah, talking to people to see if some other agency would take it. Somebody, if you know a millionaire that'd love to donate some money, I would gladly take some of that to help keep this going so we can keep training officers, not only here in Omaha, but in Lincoln, in Grand Island, in Kearney, in Alliance, in Chadron, and all that, because it's different in every area. So when you say, what can you do? Just keep advocating for these services. And so really, that's all I got. I think I tried to keep it somewhat short, so I'll stop sharing.
That was
If we got any more questions, I'll gladly keep talking.